when you are going to put your patient on the vent initially, you don't really have to have it. Okay, but down the line, if you need it, you can institute that. Okay? So inflation hold is like the breathe in, and they hold it there, and then they breathe out. So if you did inspiratory pause, okay, you would only do it one time. Patient goes, but you can actually go inside the parameter screen and set it there. If you set it there from breath to breath, the patient will hold their breath. Okay? It has advantages. Okay? It increases oxygenation. Okay, if you have your patient on the vent and you think they have enough FiO2, but the oxygenation is not going up, you can institute inflation hold. Anytime they breathe in, they hold it for a while. And this is the way it improves oxygenation. Okay? So when you breathe in, your lung units will open up this way and are held that way for the amount of time you're doing this. They're open like that. So the more time they stay open, the more gas can cross over into the blood. That's how it improves oxygenation. Okay? Equilibrates flow and pressure throughout the lung field. Now, there is something called time constant. Mrs. Cathy Brewer went over the previous ventilation plants. Time constant. Okay, so basically what time constant means is that, you know, we have millions of alveoli inside the lungs. You may have an alveoli that is like this. It's got high resistance. So this is what is normal. Let's say that this is normal. And then you have some of them that are this way. See, the resistance here is high. You may have one that has high resistance and low compliance. You may have one that has low resistance and high compliance. So each one of them may vary a little bit. So if you look at it then, if you have gas going into this and gas going into this one here, well, it will take longer for the gas to go through this one here that has high resistance before it comes down here. So basically what that means is that by the time this lung unit fills up like that, this good one here has already filled up and now begins to exhale out. See that? And then you come to this one here, it's got high resistance, you're going to have hard time for the gas to come in, and then it has low compliance. If it does come in, it goes. So it will kind of like fill up very quickly and then exhale very quickly. Okay? And then on this one here, it has normal resistance and high compliance. So it comes in, and then the lung goes like that. And then slowly it will close up. So that's called time constants. All the alveoli are different. Some of them may have secretions in them, some of them may not. Okay? So that's what we're saying here, that if you add plateau time, okay, that's another name for it, plateau time or inflation hold time or pause time. Then you hold the alveoli like that. It gives you more time for the pressure to equilibrate throughout the lung field. That's why when we're giving patients breathing treatment, we tell them to hold their breath. we want the pressure to equilibrate throughout the lung field so that every one of them will be popped open. Okay? All right. Now remember now, what actually increases oxygenation is how many alveoli you have open. Not necessarily to how much, to the extent that you distend them. Okay, so lung recruitment means opening up more alveoli. That's what lung recruitment means. Okay? Good for administration of aerosol therapy. Yeah, just like, you're giving your patient a breathing treatment, you take a slow deep breath and hold it. Okay? Now on the ventilator, if you are doing a breathing treatment, you can institute the inflation hold, okay? So that when you puff the medication down, or if you're aerosolizing it, the patient breath to breath, they're gonna be going. So they're holding your breath just like they will hold your breath if they were taking a breathing treatment. Okay? So to optimize the benefit of albuterol on the ventilator, the respiratory therapist will institute inflation hold. Okay? That's what is going to help the patient to make sure that the medication will deposit very well. Okay? But as you know, everything that has advantages also will have disadvantages. Okay? So these are the reasons why sometimes therapists will tell you, well, we never use that. Yeah, it's just there. We never use it. My God, not even turn it on. No, it's not that. It's just that you have to know when to use it. If you institute the inflation hold time, it increases your mean airway pressure. Your eye time lengthens, because now, see, if you're breathing and you're holding, you are still in inspiration, you haven't exhaled yet. So your eye time lengthens when you add pause time, okay? And your E time shortens, and your eye to E ratio shortens. So what happens then is that you are holding on that pressure inside your chest. That may affect your blood pressure, okay? Because it decreases venous return to the right side of the heart. So if I have a patient that is already very, very hypertensive, I may not want to institute inflation hold, because that will cause their blood pressure to go down even more. If you have a patient that is at the risk of barotrauma, okay, you don't want to do that, because doing that may cause them to have barotrauma, because you have all that pressure in there, you're holding it for a longer period of time. If you have a patient that has athleticism, it would be nice to institute inflation hold, because that will help stress the alveoli open. Okay? Any questions about inflation hold? So initially, you don't really need it, but if you get your patient on there and you feel like you need it, you can institute it. Okay? Expiratory retard is no longer found on modern ventilators. It's like, it mimics what do they call it? Pulse breathing. Like COPD patients, they're breathing, they pulse their lips, like that. What they're trying to do is to lengthen their expiratory time so that they have more time to exhale out. It decreases their ability to air trap. Okay, so the older ventilators had expiratory retard, which mimics that. So I teach this because sometimes it still shows up on the exam. Okay? Or maybe they can use it to write a question. So you know what it means. Okay, patient ventilator commitment. Well, the way you commit a patient to the ventilator is you get your ventilator, you hook it up to oxygen and air, you plug it into the electrical outlet. That's the first thing you do. If you know that you don't want to kill anybody, you do that first, okay? And then the next thing then is you set your parameters. don't attach your patient. You set your parameters first, because if you have your patient hooked up while you are setting your parameters, whatever, you set them goes to the patient, okay? Inspect the parameters to ensure that they are set accurately, okay? You want a PEEP of 5, well, you want to make sure that you set a PEEP of 5, not a PEEP of 50, okay? Because that will go into the patient's lungs. You want Tylenol of 500, make sure you're not setting 5,000. All right? Because if you blow up somebody's lungs, they are not going to let you go free either. Okay? Start the ventilator on. Feel for the air coming out. Just because you turn it on doesn't mean that it's working. Maybe it will start to malfunction when you turn it on. So you turn it on, you feel for the air coming out, and then you feel it, then you attach your patient. But you don't go home after that. You're not done yet. Okay, you can't say, well, I'll see you later. Okay. You have to listen to the ventilation cycle on and off. That is a sign of ventilation, that the patient is ventilating. Okay? Listen to that. You're not done yet. Observe the patient's chest rise and fall. That is a sign that the patient is getting the breaths. Auscultate the patient's chest. That is a sign that they are getting ventilation on both lungs. Okay? Observe the vital signs, right? That's what's going to tell you that they're ventilating well, they're oxygenating well, their heart rate should be coming down, their oxygen should be going up, their blood pressure should be coming down. So you look at all of those things. And then, finally, you do a vent check. Please do a vent check, because if you don't do a vent check before you walk out of there, another therapist comes behind you and changes something, right? When somebody else comes, something happens to the patient, they say, well, where is the last vent check? Well, Kiara did it. Well, you had him on PEEP of 50. Well, that's not what you had him on. You had him on a PEEP of 5, but somebody else came along and done it out. So you have to document. Anything happens, OSHA comes in, they look at that. That's a legal document if you don't know that. It's a legal document. They will look at it and see who caused it. Okay? So that's why a vent check is always good. You take your patient to a special procedure on the ventilator. When they come back, you hook them back up, you do a vent check. The ventilator is messing up and you think that you've already figured it out, and you fix it, you reconnect your patient, you do a vent check. Okay? It doesn't cost anything to do a vent check. They won't charge you any money. Perform ABG, 45 minutes to 60 minutes after that. That's the only way that you're going to know whether the patient is ventilating well or not. Okay? By doing ABG. If your CO2 is high, well, you got to adjust your tidal volume or your respiratory rate to fix that. If your oxygenation is bad, you may want to adjust your FiO2 or your PEEP to do that. Okay? So that's why we do ABG. Daily ventilator management. You do vent check. It depends on the hospital. Some hospitals do it every 2 hours. Some hospitals do it every 4 hours. So you do whatever your hospital does. Okay? But basically what you're going to do is you walk in there, you say, hey, Mr. Smith, and they're going to go like that. They can, they can talk, right, because of the cough. They go, how are you? You say, fine. Are you doing okay today? Yeah. Well, I'm going to check out your vent to make sure you're doing okay. And then you do your assessment first, because now look, the patient may actually have a lot of secretions, which is causing the PIP to go up, which is causing their heart rate to go up. They have secretions inside their mouth. They're not going to feel comfortable. When you have spit inside your mouth, you're not going to feel comfortable. If you doubt me, you can do it. You don't feel comfortable. All of that will reflect in your heart rate, okay? And agitation. So what we do first is once you go in, you introduce yourself, you look for the ambu bag. There must be an ambu bag in every patient's room that is on the ventilator. So that if the patient gets accidentally extubated, you don't have to run from the first floor to the 7th floor to find a bag. If you have to do that, by the time you come back, you may not have a patient. So it is a protocol to have an ambu bag. That's the first thing I look for. Okay? Ambu bag is there. Okay? Then you auscultate the patient, you suction them, you do trachea or whatever, or retape their ET tube. Have the patient settle down, now they're good, and then you do your vent check. So that the numbers that you're getting will reflect the patient. Now, let's say that my patient had secretions, but I didn't suction them out. Secretion is causing the PIP to go up because that's resistance. And then I got a PIP of 60. And the doctor comes in and says, oh my God, their PIP is 60 on the ventilator. Well, that's not their true PIP. The secretions made that PIP to be that high. So that's why we got to do your patient assessment, management first before you do your vent check. Okay? All right. Now let's do examples here. A 23-year-old female is admitted to the ED following a drug overdose. Her arterial blood gases on Rumed are as follows. They're on Rumed. pH 7.24, CO2 62, PO2 74, Bicart 26. The physician has written orders for intubation and mechanical ventilation. Which of the following are the most appropriate initial ventilator settings? They're on Rumed. Okay? Now, I go here. Well, what I need to do first is to calculate the tidal volume. Tidal volume rules. Tidal volume rules all the parameters. Always look at tidal volume first. If you're on pressure control, you look at pressure first. Okay? Tidal volume rules. Okay? So I'm going to do my tidal volume. So let me say, so that will be 66, 12. So is that 72 kg maybe? So 5 feet tall, that's 60 inches. So that looks like 62 kg. 62 kg. Use your height. The only time you will not use your height is when the height is not given. And then you use whatever weight that is given. Now look now, they gave me the height, they gave me the weight. Okay? I'm going to use my height because tidal volume is based on height. So 62 kg will multiply by 6. Can somebody do that? Multiply 6.
372.
Huh?
372.
Okay, 372, and then we'll multiply by 8. 372 to what?
496.
496? Mm-hmm. Okay, that's the range of tidal volume. Okay. So I know that whatever tidal volume I'm going to pick must be in this range here. Okay? And I know one thing else. They're on Rumed. So whatever FiO2 that I'm going to put them on must be between 40 to 60. Okay? So I'll go here. I'll go, well, you know, SIMV. Don't worry about the mode. The mode is not what is ventilating the patient. Any of them will be fine. As long as you have the right tidal volume, the FiO2, and all of that. 360. Well, that's low. Well, I look more. Well, respiratory 6. No, we say 10 to 20. So that whole thing is out. I don't even have to worry about looking at the rest of it. I can use it. I go to the next one. ACVC. Tidal volume 450. Well, that is in. That's in there. Respiratory rate 26. No, that's out. That's greater than 20. So that whole thing is out. Can't use it. I go to the next one, SIMV, the other one 400, well, that's in. Respiratory rate of 14, yeah, that's in, that's between 10 to 20. FiO2 65, no, the rule says that if the patient is on roommate, you have to put them on FiO2 that is between 40 to 60. So that's out as well. I go to the next one, ACVC 400, that's in. Respiratory rate 10, well, that's in. FiO2 50, yeah, that's between 40 to 60. And people 5, yeah, that's between 2 to 6. So that's what I'm going to put that patient in. Now, notice now that the tidal volume is not the smallest in the range, but the other things are correct as well. 450 is a normal tidal volume for him. If I had something, one of them has everything normal, and then I have a lower tidal volume, I will pick that one. Okay? All right. Number 2, 4 days following splenectomy, a 63-year-old, 5'8", 70 kg, pounds, has the following ABG on CPAP of 10 and FiO2 of 40. That's a blood gas. Okay? They are acidic, and the physician wants to intubate and ventilate this patient. What would I do? Well, let me go back here. Well, I know one thing to do here. I'm going to figure out the tidal volume here. Okay? So we're going to do 68 kg. 68 kg. For the height, we're going to multiply that. Can you multiply it by 6?
396.
Huh?
396.
396, 2 by 8.
528.
528. Okay, so the normal range of the tidal volume is 396 to 528. Well, I know that now. I also know that the patient is on 40%. So whatever FiO2 I'm going to put them on will be 40%. Okay? I know that they're on CPAP of 10. That's PEEP of 10. So when I put them on the ventilator, I also have to give them PEEP of 10. So I know 3 things there. So whatever answer I'm going to pick must have those 3 things. So I go, the first one says SIMVPC PRP 50. Well, no, that's too high. Remember, we said 20 to 30. Okay, the pressure of 50, if a patient has normal compliance, my God, they will get more than 1 liter of tidal volume, and that can cause barotrauma. That's very high. So the rest of the thing, is out. The next one is ACPC PRP 30. Well, that's the end, 20 to 30, that's fine. Respiratory rate 12, well, that's fine. 40%, that's fine. PEEP of 10, again, that's fine. Well, don't make conclusions yet. That's why students fail a test. The people that make out the test are psychologists. Please read all the choices before you pick one. Even if when you know that this is that's the answer, but I want to make sure I read everything. Okay? You know what they do? And the one that looks very similar to the answer is usually the A option. So immediately you see it, you go, oh, okay, yeah, that's it. Without even reading everything else. Okay? All right, so now let's look some more. PIP 25, well, that's good. That's good. Respiratory rate 26, no, that's too many respiratory rates. We say 10 to 20, so that's out. We'll go to the next one, PIP 40, no, that's above 30. So the best answer is B. Any questions about that? Number 3, 4 days following thoracotomy, which is surgery on the thorax. A 65-year-old, 60 inches tall, has the following ABGs or rheumatoid acidosis. We are going to intubate the patient here. Well, I know that the patient is on rheumatoid, and being 60 inches tall, they are going to have 50 kg. It will be 50 kg, so the other one will be 300 to 400. So I know that I have to put them on FiO2 that is between 40 to 60 because they're rheumatoid. And I know that the third one has to be in that range. So I know those two things. So let me look. First one says SIMV-BC, third volume of 350. Well, that's in there. Respiratory rate of 12. Well, that's in. FiO2 50%. That's also in. P of 5. Well, that's good. So that may be the right answer. But let's keep on looking here. And I have another one that says ACVC third volume 350. Well, that's good. Respiratory rate 12. FiO2 40. Yeah, this is less FiO2 than this one here. So remember, oxygen is drug. So this now is better than this because of the FiO2. Okay, let's keep on looking. The next one says SIMV pressure control mode 35. No, that's too much pressure. So that's out. The next one is pressure 20. That's in. Respiratory rate 15. Well, that's good. FiO2 70. No. It says 40 to 60. So the best answer is B. Okay? So, again, tidal volume rose, FiO2 is second. So you make sure that you get your tidal volume first. Okay, if you have two options that have the same tidal volume, you go to your FiO2 next. Okay? You go to your FiO2 next. Which one has a lower FiO2? And that's the one it will be. Number 4. 4 days following splenectomy. No, is that the one I just went over?
No.
Nope.
Okay.
It was thoracotomy for the previous one.
Okay, yeah, okay. Splenectomy, 63-year-old. Yeah, this is 70 inches. Okay, so now 70 inches would be 70 kg. Yeah, 70 kg there. So we have 70 kg multiplied by 6. We're going to have, is it 420? By 8, 560, right? Is that correct?
Yes.
All right. So I know that I have to pick a tidal volume in that range, and the patient has to be on 50%. ACVC, tidal volume of 500, well, that's good, it's in that range. Respiratory rate of 15, well, that's good, between 10 to 20. FiO2 of 50, yeah, that's fine. PEEP of 5, yeah, that's fine. But let me keep on looking here. Next one says SIMV-BC, tidal volume 500, well, that's good. Respiratory rate of 15, that's good. FiO2 50, that's good. PEEP of 5, that's good. And the exam, either one of them will be right. Either one of them will be right. And they will do that to you. So don't worry about that. Like I said again, the mode doesn't ventilate. What ventilates is what you have inside the mode. So if you look at two of them, they have the same thing. So they will maintain that CO2 at the same level. Okay? So you pick either one of them, you should get it right. They usually do that on the clinical simulation. They don't do that on the written test. And the clinical simulation is where you're going to see that. All right, so this next one here, SIMVPC now, pressure of 20, respiratory rate of 15, FIU to 65, that's too high. And then the last one there, we have PEEP of 10.
Do you have any bleach wipes in here, Dr. O?
Huh?
Do you have any wipes in here for the table?
No, you can come and look.
I don't see any. Is there something
I
in there?
don't see any.
Just the spray.
Sorry about that.
I do want to see. Thank you though, sorry about
Uh-huh.
that.
So, pressure here is fine, respiratory rate is high, and by the way, we can do a PEEP of 10. You will never start with a PEEP of 10 initially, never, okay? Number 5, 67-inch female patient arrives in the emergency department, intubated and being manually ventilated with 100% oxygen. Paramedics state she was discovered unconscious at home with an empty pill bottle by her side. Uh-oh, drug overdose. The respiratory therapist should select which of the following ventilator settings to best to best ventilate this patient. Well, I know that they came in with 100% oxygen. They're being back with 100% oxygen. So I'm going to put them on the same FIU to 100%. Okay? 67 inches, that would be 64 kg. 64 kg. So we figure out the tidal volume. So we'll go here. Mode. ACVC, tidal volume 500. It looks like it will be in that range, right? It looks like it. Respiratory rate of 12. FIU to 100% people 5. Yeah, well, yeah, that looks okay. And then the next one, mode, I got tidal volume of 550. No. Because the smaller the tidal volume, the better of the patient is. So that 550 is a much higher tidal volume than the other one. So I'm going to rule it out. I don't want to see it. I go to the next one, well, the tidal volume there is 702. No, so I'll take the lower one. And then I go to the tidal volume there is higher too. I always pick the lowest tidal volume. Okay. So the answer there will be A. Number 6, 65-inch 120 kg woman is brought to the emergency department and is receiving ventilation with manual resuscitator and mask at 100%. A drug overdose is suspected. After intubating the patient, the respiratory therapist is asked to recommend initial ventilator settings. What are the most appropriate settings for this patient's ventilator? Well, I'm going to put them on 100%, 65 inches, so that's 60 kg. So that would be like 360 to 480. That's the range of tidal volume there. Okay, first one here, SIMVBC, rate of 10, that's good. 700, no, that's too high. So that's out. Next one, ACVC, rate of 16, that's in, that's between 10 to 16. Tidal volume 800, no, that's too high. Then we have rate of 12, that's good. 600, no, that's high. And then you go to the last one, rate of 12, that's good. Tidal volume 450, that's good. 100%, yes, because the patient is being using 100% oxygen. Any questions about this? So the next time we have lab, we're going to have things like this, okay? All right, let me do this other lecture.